You know, I've spent decades watching how government bureaucracies operate, and there's a pattern most people miss. When the Department of Motor Vehicles quietly rolls out new regulations, they rarely announce them with fanfare. Instead, these changes slip through administrative channels, and by the time experienced drivers discover what's happened, they're already facing consequences they never saw coming. Right now, 3 significant DMV rule changes are working their way across state legislatures, and if you're over 65, these modifications will directly impact your driving privileges, your insurance costs, and frankly, your independence. I'm talking about mandatory vision rescreening intervals that have been shortened in 14 states, cognitive assessment requirements that weren't there 18 months ago, and renewal procedures that now demand in-person appearances where mail renewals previously sufficed. The remarkable thing isn't that these changes exist, it's how strategically they've been implemented during a period when 10,000 Americans turn 65 every single day. That's not coincidence. That's policy responding to demographic reality, and understanding exactly what's changed puts you in control of your situation rather than at the mercy of it. Let me think about this situation the way I've approached every complex problem in my life, by breaking it down to first principles and understanding what's really happening beneath the surface. The first rule change we need to examine involves vision testing protocols, and this is where the bureaucratic machinery reveals its true character. For decades, most states operated on what I'd call the honor system with a light verification layer. You'd renew your license every 4 to 8 years, depending on your state, and vision testing was either self-reported or conducted with such generous passing standards that nearly everyone sailed through. That system made a certain amount of sense when our population demographics looked entirely different. But here's where the mathematics become unavoidable. The Federal Highway Administration released data 18 months ago showing that drivers over 65 are now involved in intersection accidents at rates 43% higher than they were in 2010. Now, before anyone gets defensive, let me be clear about what statistics actually tell us. This doesn't mean that individuals over 65 are inherently dangerous drivers. What it means is that age-related vision changes, macular degeneration, cataracts, reduced contrast sensitivity, narrowed peripheral vision, are affecting a larger population pool than ever before in American history. The DMV didn't wake up one morning and decide to make life difficult. They woke up to lawsuit liability, federal transportation safety mandates, and insurance industry pressure that made the status quo untenable. So what actually changed in states like Florida, Arizona, California, Texas, Illinois, Pennsylvania, Ohio, North Carolina, Georgia, Virginia, Colorado, Washington, Oregon, and New Jersey, vision screening intervals have been compressed. Where you might have gone 8 years between vision tests, you're now looking at tests every 2 to 4 years once you cross the 65-year threshold. Some states have implemented what they call graduated screening, which is bureaucratic language for more frequent testing as you age. Hit 70 and you're testing every 2 years. Hit 75 and in some jurisdictions it's annual. The stated rationale is accident prevention, but the unstated rationale is liability management. Every government agency operates with one eye on the courtroom, and when a 72-year-old driver with untreated glaucoma causes a fatal accident at an intersection, the plaintiff's attorney immediately pulls that driver's renewal records. If the state allowed an 8-year gap without vision verification, that becomes Exhibit A in a negligence lawsuit against the Department of Motor Vehicles. Now let's talk about implementation, because this is where theory meets reality in ways that create real hardship for real people. The vision standards themselves haven't necessarily changed in most states. You still need 20/40 vision in at least one eye, sometimes correctable with lenses. What's changed is the enforcement frequency and the documentation requirements. Some states now require vision reports directly from licensed optometrists or ophthalmologists rather than accepting the DMV's in-house screening. That means you can't just walk into the DMV, read the eye chart, and walk out with your renewal. You need a separate appointment with an eye care professional. You need them to complete specific state forms, and you need to submit that documentation within a specified time frame. For someone living on Social Security in a rural area where the nearest ophthalmologist is 45 miles away and booking appointments requires a 3-month wait, this isn't a minor inconvenience. This is a substantial barrier. The second rule change involves cognitive assessment, and this is where the situation becomes significantly more complex from both a civil liberties perspective and a practical safety perspective. 15 states have now implemented some form of cognitive screening for license renewal after age 70, and another 8 states are piloting programs that will likely become mandatory by late 2026. The assessments vary wildly in scope and rigor. Some states use a simple written test that evaluates basic traffic law knowledge and decision-making scenarios. Other states have adopted computerized cognitive assessment tools that measure reaction time, divided attention, visual processing speed, and executive function. The most aggressive programs require what amounts to a mini neuropsychological evaluation. Here's the uncomfortable truth that nobody in politics wants to say out loud. Cognitive decline is real, it's progressive, and it absolutely affects driving ability. Dementia and mild cognitive impairment don't announce themselves with obvious symptoms. A person can maintain social conversation, manage household tasks, and appear entirely competent while simultaneously losing the rapid information processing capability required to navigate a 4-way stop with multiple vehicles approaching from different directions. The Alzheimer's Association estimates that approximately 15% of Americans over 65 have some form of dementia, and an additional 22% have mild cognitive impairment. That's more than 1 in 3 people. These individuals don't suddenly become dangerous drivers overnight, but their margins of error shrink, their reaction times lengthen, and their ability to handle unexpected situations deteriorates. The DMV's challenge is creating a screening system that identifies genuinely impaired drivers without unfairly penalizing the 63% of seniors who are cognitively intact and perfectly safe behind the wheel. This is where the testing controversy emerges. The computerized assessments being used in states like Maryland, Iowa, and Illinois were originally developed for clinical dementia diagnosis, not for licensing decisions. They're being repurposed for a regulatory function they weren't designed to perform. The result is a meaningful number of false positives, people who fail the screening but are actually competent drivers, and an unknown number of false negatives, people who pass the screening but probably shouldn't be driving. What makes this particularly insidious is the administrative process that follows a failed cognitive assessment. In most states, failing the initial screening doesn't immediately revoke your license, but it triggers a requirement for evaluation by a physician, often specifically a neurologist or geriatric specialist. That evaluation must address specific questions about the person's cognitive status and their fitness to drive. Now think about what you're asking a physician to do. You're asking them to make a judgment that will determine whether their patient retains independence and mobility. The physician knows that if they clear the patient and that patient subsequently causes an accident, the physician's medical license and malpractice insurance are on the line. The incentive structure pushes physicians toward conservative recommendations. When in doubt, recommend license restriction or revocation. It's the safe choice for the physician, but it's potentially devastating for the patient. The third rule change involves in-person renewal requirements, and this represents a complete reversal of the trend toward convenience and digital services that we've seen in virtually every other area of government administration. For the past 2 decades, states have been moving toward online renewal systems. You go to a website, you verify your information, you pay your fee, they mail you a new license. It's efficient, it's convenient, and it reduces the burden on DMV offices that are perpetually understaffed and overcrowded. But starting in 2023, states began carving out exceptions to online renewal eligibility, and the primary exception category is age-based. As of right now, 22 states require in-person renewal for drivers over a certain age threshold, typically 65, 70, or 75. The official justification is identity verification and fraud prevention, but let's be honest about what's actually happening. This is a face-to-face Screening opportunity. When you appear in person, the DMV clerk is making observational assessments. They're watching how you walk, how you communicate, whether you seem confused or disoriented, whether your physical presentation raises red flags about fitness to drive. This isn't documented in any formal way, and the clerks aren't trained medical professionals, but they have discretion to flag applications for additional review if something seems off. The implications extend beyond the screening itself. In-person renewal means taking time off if you're still working, arranging transportation if you no longer feel comfortable driving in unfamiliar areas or heavy traffic, waiting in line for potentially hours at understaffed DMV offices, and navigating bureaucratic systems that aren't designed for people with mobility limitations, hearing impairments, or other age-related challenges. I've read accounts of people spending 4 or 5 hours at the DMV for what should be a 15-minute transaction, standing in lines because there aren't enough chairs, filling out forms with tiny print that's nearly impossible to read even with corrective lenses, and dealing with clerks who are processing hundreds of people per day and have zero patience for questions or confusion. Now let me address the question that's probably forming in your mind. Are these rule changes justified or are they discriminatory? The answer is both, and that's what makes this situation so difficult to navigate. From a pure public safety standpoint, age-correlated screening makes statistical sense. Crash rates, injury severity, and fatality rates do increase with age, particularly after 75. The Insurance Institute for Highway Safety publishes data showing that per-mile driven fatal crash rates begin increasing starting at age 70 and rise sharply after age 80. If your goal is reducing traffic fatalities and serious injuries, targeting screening resources toward higher risk age groups is rational policy. But rationality doesn't exist in a vacuum. We're talking about a population that built the interstate highway system, that created the car-dependent suburban landscape that defines most of American geography, and that has spent 50 or 60 years organizing their entire lives around the assumption of automobile access. Taking away someone's license doesn't just limit their mobility. It often eliminates their ability to access medical care, purchase groceries, maintain social connections, and live independently. In rural America and suburban areas without public transportation, losing your license is functionally equivalent to losing your independence. That's not hyperbole. That's the lived reality for millions of people. The policy question becomes whether we're implementing these screening requirements because they genuinely improve safety outcomes, or whether we're implementing them because they shift liability away from government agencies and onto individuals. I suspect the honest answer is that both motivations are operating simultaneously, and the relative weight of each varies by state and by the specific political pressures facing each state's Department of Motor Vehicles. So what do you do with this information? First, understand that these rules exist within state-specific regulatory frameworks. Every state sets its own licensing requirements, and there's enormous variation in how aggressively these changes are being implemented. If you're in a state that's already enacted strict age-based screening, you need to know exactly what's required and plan accordingly. Don't wait until your license is expiring to figure out that you need a vision report from a specialist with a 3-month waiting list. Don't assume that the renewal process you used last time will still be available this time. Second, take the screening requirements seriously, but understand that they're not designed to catch every possible impairment. The vision tests are testing specific measurable parameters. The cognitive assessments are testing specific domains of mental function. If you have concerns about your own abilities, if you're finding driving more stressful, if you're avoiding certain situations like left turns across traffic or nighttime driving, if family members have expressed concerns, those are signals worth paying attention to, regardless of what any DMV screening shows. The tests are crude instruments. Your own self-awareness and the observations of people who know you well are often more accurate indicators. Third, recognize that maintaining your license requires maintaining your capabilities, and that's something you have more control over than you might think. Vision changes can often be corrected or managed with updated prescriptions, cataract surgery, or treatment for conditions like glaucoma. Cognitive function can be supported through physical exercise, social engagement, cognitive challenges, management of cardiovascular risk factors, and treatment of conditions like sleep apnea that impair mental sharpness. Physical limitations that affect your ability to turn your head to check blind spots, operate pedals effectively, or react quickly can sometimes be addressed through vehicle modifications, physical therapy, or strength training. The fundamental issue here is that we've built a society where driving isn't optional for most people, and we're now implementing screening systems that will identify increasing numbers of people as unsuitable for driving, without providing meaningful alternatives for how those people will maintain their independence and quality of life. That's a policy failure, and it's one that's going to become more acute as the demographic wave of aging baby boomers continues to crest over the next 15 years. The answer isn't to eliminate screening, genuine safety concerns are real, but it is to recognize that screening without support systems is simply abandoning people to cope with loss of independence on their own.